Hi, Davin.
Sandra, good to work again with you.
Yes, of course. Thanks for your time today. I really appreciate it. I know how busy you are. And I just wanted to take the opportunity to ask you a few questions.
I know you're going to be hard because every time you ask me, it's going to be challenging questions. Yeah, go on.
I just wanted to ask you a few questions regarding the treatment of Asian skin type with the Picosure Pro. I know you're really familiar with Picosure. Look, now you have been working with the latest generation of Pico, which is Picosure Pro. Look, what is your feedback about treating, for instance, single pigmented lesions? You know, how do you approach it? I mean, knowing that you can use more power now. Are you looking at whitening or, you know, or frosting of the pigment? What's your feedback? How do you find the pigment are clearing faster? Do you get as much side effect?
I think to answer that question, you've got to look historically. So let's say even 10 years ago or even longer, right? And how we used to treat these pigmented lesions. So in the past, we used to use things like Q-switch lasers, yeah? And when you look at the side effects of Q-switch lasers, generally speaking, in the best hands, you're going to get about 20 to 25% PIH.
Yeah.
But with Q-switch lasers, once you get that endpoint of you know, stipple frosting, generally speaking, you're going to get a good result with it. You may have erythema that lasts 6, 8, 10 weeks. You can mitigate some of the PIH with corticosteroids, but generally that's the endpoint. Now, when you talk about Pico, right, you can get a good result, but your PIH rate is much less. So anywhere between 3 to 5%.
Okay.
So we've got to remember that it's not about total mitigation of side effects, but a marked lowering down of side effects. And this is where my protocol and the way I think is based on, right? So we all know that if you use different wavelengths, when you're talking about epidermal lesions, you know, basically your wavelengths, because it's superficial, either you're 532 or you're 755, right? And some companies got the 730, and even before that, 785. So what I like to use, when you think about things logically, right, the wavelength of choice in the context of Pico, it should be 755.
Yeah.
The reason, because when you look at the melanin to hemoglobin ratio, right, you're looking about 54 to 1. When you're looking at the 532, you're looking at 2.6 to 1. So for me, I get a stipple frost endpoint.
Okay.
The reason for that is I know when I get that, the chances of clearance is a lot higher. And I may not get it in one session. Sometimes I do. But I may get it in 2 sessions and definitely by the 3rd. So I think to answer your question is that I do look at that endpoint, right? Yeah. But once again, I base that endpoint when I look at, if I treat 100 patients with it, and if I have a nice even stippling, how much will get PIH? And it's probably around 5%, which I can accept as a good treatment, because I do get the results but mitigate the side effects.
Yeah, no, really informative, and that's really important, because again, you know, we are all learning how to master, you know, different technology, and sometimes we know, you know, we have clinical endpoint to look for, but sometimes we know this type of clinical endpoint can be quite
and I think
leading to side effect on some of the skin.
But
it's really a juggling act.
Yeah, a juggling act. But then you know, you have different physicians. Some physicians want like a pH rate of 1%, right? Yeah. And if they want that, I understand that. So they may have to do 3, 4, 5 sessions, right? But the endpoint may just be a little bit of erythema, a little bit of edema.
That's correct. Right? Yeah.
So it all depends on your being sensible, I guess.
That's correct.
But also look at the you know, historical data. So I think that's very important.
No, really, really helpful. Another question I have is on the treatment on skin revitalization on Asian skin, or what we call mainly, I know in the Asian community, you know, they love to call it, you know, the Pico toning, the Pico brightening, the lightening. Okay. So what's your approach to it? How do you treat this concern?
Yeah. So I mean, once again, when you look historically, that was using the Q-switch lasers. So the Koreans were doing it many years ago, and they often start at something like, you know, 1.2 all the way up to 1.6, 1.7. That's pretty high, but most of them are using an 8 mil low fluence, and they do it every 2 weeks, right? And the aim of that is to lighten, brighten, improve skin quality, reduce, you know, fine lines, wrinkles, a little bit of background pigment, and just give skin an overall glow. So if we use that basis, but then extrapolate it to the Pico, in particular Picosure Pro, you know, you can use one of 2 things. Like you mentioned, you can use the flat spot, right? And in that situation, you might want to use an 8 mil. Remember, the bigger the spot size, the deeper it goes. So you might want to use the bigger spot size within possible limits, and then low fluids, like a 0.4. Now, I guess when you're combining the focus, there's two schools of thought. Number one, absolutely no downtime. If you have absolutely no downtime, you might want to use the lowest fluids possible in the biggest spot size. Me, on the other hand, right? Because look, I like to get the job done, right? So you know, as much as I love patients, I like to actually get things done. I like the wow factor.
Yeah.
So what I would do safely is to use something like a 6 mil focus, right? And I would dial it. If you want minimal downtime, 0.58.
Yeah.
If you want good effects where you can see like things, probably dial it up to 0.7. You don't need to go up to the 0.8, 0.9 in that type setting. So something like a 0.58, and maybe do 2-3 passes, something like 2,000 to 3,000 shots.
Okay.
That you get a wow. So if you select the patient, you do 2 treatments, and then before and afters, it's a pretty good result.
Yeah. And would you combine this basically 2 or 3 passes with focus with 2 passes of flat before that?
Yes.
Okay, you'll get a total approximately of 5,000
Yeah.
pulse.
Yeah. I mean, that's
2,000, 3,000.
Yeah.
Okay, that's really informative, and in a way you're looking obviously a bit more swelling, a bit more redness, you know.
That's minimal.
But that's minimal.
Yeah.
We know that it clear really
minimal.
quickly.
Yeah.
Now, a quick question on this topic: have you been using 5mm spot size or new 5mm spot size on Asian skin? Or do you think it's a bit too strong yet?
I think so. My girls use it on the flat. I try. I think when you've got a new system, you've got to actually be pretty consistent with your things. Actually, really understand what it is.
Yeah.
So I think, you know, because of the 5 mil probably can exert more energy, right? And I think that is a possibility with a flat. I personally like using the 6. And you know, off camera, I'll tell you I focus, defocus. So you know how I do things, and I listen, and also I'll see the endpoint as well. So you're absolutely right. I think 5 mil when you're starting out, just to see the endpoints, that's good. I personally stick to the 6 mil.
Okay, no, that's good to know. You know, some of the clinic are a bit scared to jump from an 8 to a 6.
Yes,
you know. And we know the beauty, obviously, now to be able to change the energy will be then progressively with your 8mm reaching similar energy than your 6.
Then your 6, yes.
And slowly you can move to a different spot size. Now, my last 2 questions, and I know we're going to have to go. We have a big event today. My last question is about melasma. I know that's really complicated. Everybody always asks and want a sort of miracle or protocol, you know. I know your answer is not going to be a straight answer, but how do you tackle melasma with Pico?
I think the first thing, you know, like I say, it's a complex thing. Anyone who says I've got a really good program for melasma and I treat most patients, probably lying, right? Yeah. So I think the first thing, like I say, you know, your basic medical, whether it be your sun protection, your hydroquinone, your tea acid, your arbutin, licorice root, your a whole heap of different stuff that suppresses the pigment. In the context of melasma, our aims is very low treatments, right? So you might want to do something like a flat, like you mentioned, something like an 8 mil. I found out the sweet spot for me is probably using the 6 mil once again, right? The 6 mil is what I use for the dermal toning settings. But bearing in mind, those original settings were 1064, and now using a 755. But the flip side is this. When you look at the histology of melasma, we're talking about normal melasma. We're talking about recalcitrant dermal melasma. We're talking about just normal melasma where you have epidermal, a tiny bit of dermal. It just makes sense with the 755 because the 1064, in theory, when you think about the epidermal bypass system, right, you miss out there but treat out here. Certainly for things like, you know, resistant dermal melasma, that may be an appropriate wavelength. But I think when you're talking about epidermal or epidermal much greater than dermal, probably the 755 in using between the 6 to 8 mil.
And in your treatment protocol, would you recommend to treat every 2 weeks? I heard that, I'm not sure, someone was telling me it's probably better to treat every 2 weeks than waiting every 4 weeks. Yeah,
I guess there's two things. When you look at the side effects, right, and this happens with the Q-switch, where you have a melanocyte death. Generally speaking, if you treat at intervals of 2 weeks or greater, that's not going to happen, right? So I think following that is probably advisable.
A good advice.
So I personally do every 3 to 4 weeks.
Okay. And last question is about the speed. frequency, you know. Does it really matter if you treat melasma on 5 hertz, 1 hertz, 10 hertz?
You know my answer because I'm a very quick worker. So
it's going to be 10 hertz.
It's going to be 10 hertz. Yeah, but 10 hertz, but move very quickly.
That's
that's the thing. Yeah.
Donc you would recommend to a beginner, let's say a beginner, to use more like a 5 hertz,
5
maybe?
hertz. Yeah, exactly.
To minimize overlapping and hitting too much the area.
But once again, you know, I guess have I got any? Yeah, I've got laser marks on my hands. Yeah, because that way when you use, let's say, low fluence and 10 hertz, when you shoot your hand, you can understand the heat build up with it.
Yeah.
So I think, you know, even for beginner, they understand between 5 and 10 and how fast to move, usually within 1 day.
Yeah.
Yeah, because they get that feedback, and then muscle memory just kicks in.
Yeah.
Right. And if you're in doubt about how much heat you're generating or how painful, just hit your hand. Right. And when you're using low fluence to treat melasma, it's not a big problem generally, but you just got to move quick.
Yeah. And do you focus really on number of passes, or just at obviously looking at the response, because you can have a bit of a delay response? Yeah. Sometimes.
I guess there's 3 ways. You can look at the response. You can also look at your how much passes you do, or you look at the shot count. So for me, when I'm giving melasma to my patients, for my nurses to do, I go by the shot count, right? Because when I look at the patient, for example, someone's got isolated melasma, we may only go for 600-700 shots. And then someone who's got extensive melasma, you know, whether it be mandibular melasma, and then they have forehead centrofacial, you know, we might go for 2,000 shots. So when I write down in my notes, aim 2,000 shots, and the nurses know, hit that area, but move quick. Total, all they look is a screen, total 2,000 shots. That's how I do things. The other, finally, I also listen to what it's telling me to do, because when you hear that bang, bang, bang,
the snapping.
Yeah, snapping. Yes, you know, you may have your hair follicles there, debris and all, but I use that, you know, as I guess a guide to the amount of melanin in the actual skin.
And would you also combine with a focus a bit, or you just stay flat? You think focus will get too much heat?
Yeah, I mean, I think you can stay flat, but I've got, and you'll see with some of the photos, I've got some really outstanding results using low fluence, not high fluence, very 0.58, 6 mil focus, moving very quick, conservative shots, you know, 2000, 2005, but once again, you know, I think this is difficult because melasma is difficult. It's
difficult, and you can't really find a magic
solution
yet. It's just a combination also of different modality and approaches. Thanks a lot, Davin. I mean, I could continue to chat for much longer. You know, I think we can go on for all days, but we have to stop for now. I really appreciate your time.
Thank you.
That's for the clinical global team, I suppose, you know, and that's it. Bye-bye.
Bye.